Okay, fantastic. Okay, thank you, everybody. It's my great pleasure
Not
today
yet,
to...
not yet. Give
Not
me one
yet?
second.
Wow, okay.
Mute this.
Go
Okay,
ahead.
take two. Okay, everybody, welcome today. It's my great pleasure to introduce Dr. Sergio Caravita here with us. Dr. Caravita is Associate Professor of Cardiovascular Medicine at the University of Bergamo. He earned his medical degree from the University of Milan Bicocca, that also happened to be mine alma mater, where he also completed his cardiovascular fellowship, a master in advanced heart failure. He then earned a PhD from Brussels University. His research and clinical interests involve pulmonary hemodynamics, right heart function, heart failure, and exercise physiology. And he's here with us today to talk about exercise right heart cath in patients with preserved ejection fraction heart failure and tricuspid valve assessment. Thank you so much, Dr. Caravita, for being here with us today.
Thank you, Francesco, and thank you for your kind invitation. I'm very glad to be here with you today to talk about these topics, which are among my preferred ones. So, uh, why we talk of exercise right heart cath or invasive cardiopulmonary exercise testing in this context, in patients with HFpEF and tricuspid regurgitation? Well, because we assume that invasive is something precise, which provides us useful information to better clarify the nature of symptoms in the individual patients in order to better answer to their complaints and to tailor intervention. This precision overcomes the limitations of non-invasive techniques such as echocardiography, standard cardiopulmonary exercise test, and CPET combined with exercise echocardiography. And when we approach patients with HFpEF, since the definition of HFpEF itself is quite complex and non-univocal, I like to start with this introduction. So, paraphrasing the Brunwald's definition of heart failure, the inability to pump blood or to do so at the expense of high filling pressure. Well, I like very much this definition because it does not provide any threshold, any cutoff. It is something we can somehow interpret and paraphrasing it, it means that a patient with a PEF can be a patient with high filling pressure, high wedge, with normal cardiac output. And if we move forward, we can accept the fact that this may occur at rest in the more advanced phases or during exercise, typically when patients complain symptoms. So having a photograph of what's happening in the heart of a patient with a PEF during exercise provides us many more information than those we can detect from other techniques. Now, the problem here is which threshold do we apply to define high filling pressure? What is normal? What are the upper limits of normal? Since it is not routine care, having a right heart cath in patients with in healthy individuals, we should go back at the 70s, 80s of the last century to see that healthy individuals may have wedge pressure or left ventricular and diastolic pressure during exercise not exceeding 20 to 25 millimeters of mercury. For sure, we have an effect of aging. So, irrespectively of the healthy status, age per se may contribute to rise filling pressure during exercise. However, despite this, we accept that the threshold of 20, 25 to be more inclusive is not the normal individual should not go beyond this threshold. uh, accepting also the fact that if we have a healthy athlete exercising to very high workload, wedge pressure lose its meaning, its meaningless. In other words, we can have normal people, healthy athletes having very high wedge at peak exercise, which is the reason probably why they can reach such high workload. And these preliminary evidence were taken in this seminal paper by Barry Borlaug and co-workers in 2010, when they published Exercise Hemodynamics, Enhanced Diagnosis of Early HFpEF. Basically, they recognize the fact that we may be confronted with patients complaining of exertional breathlessness, and that many of these patients may not fulfill the traditional criteria for heart failure based on echocardiography, natriuretic peptides, and so on. Here you see this initial cohort of the Mayo Clinic composed by patients with non-cardiac dyspnea. They were defined non-cardiac dyspnea after exercise right heart cath and HFpEF that were identified after exercise right heart cath. I would like to point out the fact that there are minimal differences between the two groups in terms of echocardiographic features, and that many parameters fall within normal limits, also in patients with HFpEF. Consistent with this, when these patients were brought to the cath lab and wedge pressure measured in resting condition, they had normal wedge pressure. But simple provocative maneuvers such as raising the feet by connecting them to the pedals of the ergometer was able to rise wedge pressure in HFpEF patients that are here depicted in red, much more than what observed in patients with non-cardiac dyspnea, here depicted in green. And more importantly, just after 1 minute of exercise at 20 watts, on average, HFpEF patients had wedge pressure well above the threshold of 25 millimeters of mercury. Even more so as exercise went on up to peak. But the majority of the effect was already visible after 1 minute of exercise at 20 watts. What is extremely important, again, is the fact that all these alterations are extremely transient. So 1 minute after the end of exercise, we have a near normalization of hemodynamics, suggesting once again the importance of acquiring continuous information throughout the test, such as what we can do with right heart cath, as opposed, for instance, to the practice of performing an exercise echo, or better, having a patient exercising and then doing an echocardiography immediately after the exercise. We may miss the great majority of alterations that occur dynamically during the test. Now, since 2010, a lot of research has been done, and now we know that the ingredients to make HFpEF are left ventricular stiffening. Okay, this is something we knew since quite a lot of time, but we have a relevant contribution also of left atrial myopathy, meaning stiffer left atrium or a reduction of left atrial compliance, mainly due to an overstretching of the left atrium, which occurs dynamically due to the high left ventricular end diastolic pressure. This determines the appearance of quite tall V waves in the wedge pressure position, despite the absence of significant mitral regurgitation. And we have also the role of dysfunctional preload. In other words, we have our volume reservoir especially in the veins of the abdomen, that during exercise may become squeezed, and this reservoir of volume is shifted from the abdomen to the chest and invades the left ventricle, which is stiffer than expected, contributing to all the alteration we have seen so far. Now, one important aspect that has been highlighted in the last year is that we can define HFpEF based on absolute wedge pressure thresholds, as shown by Barry Borlag and colleagues, or we can adopt flow normalized thresholds. In other words, since pressure and flow are strictly interdependent, we cannot generate pressure without flow, and we cannot generate flow without pressure gradients. We can normalize the increase in wedge pressure for cardiac output increase. In practice, we collect pairs of wedge pressure and cardiac output at rest with feet on the pedals and during several steps of the exercise. And by interpolating them linearly, we derive a slope which can help us detecting HFpEF. And that can be particularly useful, for instance, when the patient interrupts the effort due to non-cardiac problems, orthopedic problems, technical problems. We have a submaximal information that help us determining whether the patient has HFpEF or not, because a wedge pressure cardiac output slope above 2 millimeters of mercury per liter per minute has been shown to be indicative of this condition. So we can use it when we have technical problems, patient interrupting for pain in the leg, for instance, which can unfortunately occur from time to time in the cath lab, or in a situation of preload deprived individuals. The typical example is that of patients with a pulmonary vascular disease, PAH or CTEF, plus HFpEF. The two conditions sometimes can coexist. They may create some problems. And what we typically see in patients with PAH who also have a coexistent HFpEF is that the slope of the relationship between wedge pressure and cardiac output is steeper than normal, despite the fact that they do not reach the threshold of 25 millimeters of mercury of wedge pressure. Probably because since they have a pulmonary vascular barrage impeding in a certain way proper filling of the left ventricle, the relative increase in wedge pressure is steeper, despite they do not reach the absolute threshold of 25 millimeters of mercury. Now, all this information have been recently reviewed and put in a very nice document from the American Heart Association on standardization of baseline and provocative invasive hemodynamic protocols for the evaluation of heart failure and pulmonary hypertension. There is a specific section on exercise stress test that can be performed either in the supine position, as is generally done in several cath labs, or in the upright position, so that a true invasive cardiopulmonary exercise test is performed. Both tests have pros and cons, obviously. What I would like to highlight here is that today, after more than 15 years of work on this topic, we have quite homogeneous definitions of HFpEF based either on supine or upright exercise. For sure, in the upright position, we have lower cutoff absolute thresholds to diagnose HFpEF. In both cases, we accept the wedge pressure cardiac output slope as a useful parameter to diagnose this condition. And when thinking about the possibility of performing one or the other exam, it is important to keep in mind which is the rationale, the pros and cons, the advantages and disadvantages of each condition. Because for sure, supine exercise right heart cath is very practical. The patient should not be mobilized, moved from the cath lab, so it is safer for sure. We do not have the risk of falls. We can have, on the other hand, with upright exercise right heart cath, but we should keep in mind the fact that supine exercise right heart cath is done in a quite unphysiological position, with the feet of a patient elevated above the level of the bed and of the heart. So it is a condition which somehow magnifies preload as compared with upright testing, where due to gravitational forces, preload, at least in resting condition, is reduced. But we have also seen that some patients with HFpEF, especially elderly patients with comorbidities, with venous insufficiency, with dysautonomia, may sometimes present divergent responses in the two settings. So they may present with a steep increase in wedge when exercising supine, and a shallower increase in wedge when they are exercising in the upright position. Just to give you an example, this is a typical patient, top left, that resting condition have a borderline wedge, pressure of 14 at end expiration, and that during low workload exercise, 20 watt, has a wedge pressure going above 25 millimeters of mercury, with the development of discrete V waves, suggesting the presence of a stiff left atrium in the supine position. When we redo the test in the upright position, we have extremely lower values of wedge pressure, both at rest and during exercise, even though the relative increase in wedge pressure normalized for cardiac output increase may maintain consistency in the two tests. For instance, upright testing may be more useful when we have the suspect of preload failure, or when we have a suspicion of dysautonomia and so on, while the supine testing may be even more sensitive because we have this preload magnification, which contributes to unmask certain abnormalities in the stiffness of the left ventricle and in the compliance of the left atrium. But now, all the elements that contribute to the dynamic change in left atrial pressure, wedge pressure, and contribute to exercise pulmonary hypertension, on one side, drive lung congestion, something that can be seen directly with ultrasound. Through lung congestion, we assume that wedge pressure contributes to dyspnea perception, and the rate of increase in wedge pressure has been associated with adverse outcome, both when we consider it in absolute values or in flow cardiac output normalized values. So all this seems to be quite consistent across cohorts across the world. And the fact that wedge pressure is a good proxy for the intrinsic alterations of HFpEF is further reinforced by the fact that if we treat patients with hemodynamically proven HFpEF with dapagliflozin, we can see for sure a reduction in wedge pressure at rest, but even more so during exercise, as Borlag and colleagues showed a couple of years ago in the Cameo data trial. Interestingly enough, and providing consistency and robustness to exercise right heart catheterization, patients treated with placebo did not change their wedge pressure neither at rest nor during exercise, suggesting that retest evaluation of wedge pressure at rest or during exercise may be consistent in a given patient who is not treated. So we have today drugs for HFpEF, such as SGLT2 inhibitors. Exercise hemodynamic is increasingly used to evaluate the candidacy and the efficacy of device treatment in heart failure, from left atrial decompression therapies, interatrial shunting therapies, in which we aim at decompress the left atrium by creating an interatrial shunt, or in the context of preload modulation through splanchnic nerve ablation, which may contribute to reduce the venous vasoconstriction we typically have during exercise in order to avoid the shift, the redundant shift of blood volume from the abdomen to the chest during exercise, thus reducing the extent of wedge pressure elevation. So all this is a sort of overview of quite simple overview of what we have now in the setting of HFpEF, in particular when focusing on the left side of the heart. But exercise hemodynamics is particularly relevant also to track the transition from a left heart phenotype to a more worrisome right heart phenotype, which starts from the left. So all the alteration we have seen so far, for sure, contributes over time, repetitively, to increase right ventricular pulsatile afterload. We have a wedge pressure mediated reduction of pulmonary compliance, which impacts on the pulsatile afterload of the right ventricle, may contribute to pulmonary vascular remodeling, especially of venous pulmonary vascular remodeling, but also in minor part of arterial remodeling, thus contributing to an increase in pulmonary vascular resistance and steady afterload. All this has for sure an impact on right ventricular function, which is a strong prognosticator in heart failure in general and in HFpEF in particular. But we have a parallel pathway, which may be even more relevant, in my opinion, for HFpEF, and which reflects the strict interplay we have between HFpEF, intended as a problem of the left atrium, a left atrial myopathy characterized by high left atrial pressure, because patients who are diagnosed with HFpEF based on exercise hemodynamics have a great propensity to develop or worsen their burden of atrial fibrillation over time. And this is extremely relevant because atrial fibrillation is associated not only with left atrial remodeling, as we are more focused on to, but also on right atrial remodeling. The Mayo Clinic which has brought us the great majority of evidence in the field of HFpEF, showed some years ago that once persistent atrial fibrillation ensues, the dilation of the right atrium is not uh, is to a certain extent comparable to that of the left atrium. The problem here is that the tricuspid annulus is by far less rigid and robust than the mitral annulus. So as the left atrium dilates, it may promote atrial secondary mitral regurgitation in about 10 to 20% of patients. But the proportion of patients developing significant tricuspid annulus remodeling and accordingly moderate to severe tricuspid regurgitation is absolutely not negligible. At least 30% of patients developing persistent atrial fibrillation may present with a significant tricuspid regurgitation due to this atrial mechanism. The right atrium dilates and the tricuspid annulus follows simply. In terms of interlink between TR and HFpEF, beyond sharing a common denominator, which is atrial fibrillation, if we take a cohort of patients with severe TR, the prevalence of hemodynamically proven HFpEF may be as high as 70%. On the other hand, if we take cohorts of patients with hemodynamically proven HFpEF, the prevalence of moderate to severe TR may be variable, but up to 1/3 of patients. And not last, TR may increase, may worsen during exercise in over 50% of patients. So what we are seeing in resting condition may not necessarily reflect the relationship between symptoms development and TR severity. So just to give you an example and try to be more practical, a typical elderly female Italian woman, normal weight, with an history of mild hypertension or in permanent atrial fibrillation since 4 years, was seen because worsening dyspnea in the last year plus mild peripheral edema. She was started with furosemide and gliflozin with disappearance of edema, but no clinical improvement, so that she came to our dyspnea clinic. The fact she is 8 years old and plus atrial fibrillation provides her more than 90% probability of HFpEF. And when performing echocardiography, we saw moderate to severe TR plus features of HFpEF, including an enlarged left atrium and a high probability of pulmonary hypertension. So in order to better understand the impact of this moderate to severe TR and what to do next, we decided to brought her to the cath lab. Here I reported you the numbers and just to reason on that. So mean PAP is 25, so pulmonary hypertension post-capillary because an end-diastolic wedge pressure of 17 plus V waves at 27. Normal right atrial pressure at 4. Low cardiac index, even though the patient is 80, so limits of normal for an 80 years old are not necessarily adequate, and PVR slightly at the upper limit of normal. Beyond numbers, I always like to have traces under the eyes because I think they provide much more information than just numbers. So here we can clearly see that wedge pressure is quite high and V waves are clearly apparent, suggesting the presence of reduced left atrial compliance. So it seems to be a typical HFpEF with post-capillary PH and tall V waves, suggesting left atrial myopathy. But if we look in detail at right atrial pressure trace, we can see that inspiratory changes of right atrial pressure are not that marked, and we have quite deep wide descent, which is not necessarily a benign sign. And when we had the patient exercising, what you can see here is that wedge pressure barely rose above resting values, while we had a steep increase in right atrial pressure with very tall V waves exceeding wedge pressure in the inspiratory phase and suggesting enhanced ventricular interdependence. And even though cardiac index more than doubled during exercise, or better, cardiac index more than doubled during exercise, uh, and she had a quite good peripheral oxygen extraction, which provided her a normal peak oxygen consumption. So basically, this patient is symptomatic, but she has a normal exercise capacity, normal peak VO2. Accordingly, the hemodynamic aberrances we can see in patients with HFpEF and tricuspid regurgitation have been already well highlighted. So typically, despite starting with quite high wedge, patients with HFpEF and tricuspid regurgitation may present with a blunted increase in wedge pressure during exercise as compared with patients with HFpEF and without TR. And this is due to the enhanced ventricular interdependence that can occur in these patients presenting with higher right atrial pressure at resting during exercise, high V waves, so that the ratio between right atrial pressure and wedge pressure becomes more defavorable during exercise. All this is accompanied generally with a lower cardiac output response. So here you have patients with HFpEF and tricuspid regurgitation in red, patients with HFpEF and without tricuspid regurgitation in black. These isoflex represent a combination of cardiac output and arteriovenous oxygen difference. Their product is the same along these isoflex, suggesting that patients with TR may present with similar oxygen consumption at peak exercise as compared with patients without TR, but they can achieve such a peak VO2 thanks to an enhanced peripheral extraction of oxygen. So they are hyper extractor. They somehow compensate their lower cardiac output by increasing and maximizing peripheral oxygen extraction. Now, this is relevant to understand the pathophysiology and TR. What I would like to end with in this section is the fact that exercise hemodynamics is really powerful because sometimes you have patients with completely normal right atrial pressure at rest that during low workload exercise develop very tall V waves. So this is something we can see at very low workload. And even in the patient who has been overdiuresed, so a lot of diuretics leading to normal right atrial pressure together with low cardiac output, by having passive leg raising, so increasing preload and mild exercise, we can detect the hemodynamic impact of TR. And even if a patient has high PVR at rest due to low cardiac output, by this means, we can see how PVR, by increasing cardiac output, decreases during exercise. So in this case, we had PVR above 6 at rest that became 3 during exercise because probably the patient had received too much diuretic. As a final flash, in terms of what we can obtain further from hemodynamics, is I would like to bring you a couple of cases of right ventricular pressure volume loops, because I think that this contributes to highlight the need for stressing the system. So here we have two patients, both considered to have moderate to severe TR. Patient 2 has a higher right ventricular systolic pressure, so higher PAP, does not present with isovolumic contraction, suggesting very severe TR, at larger volume than patient 1, and higher right ventricular and diastolic pressure. So if we remain settled on resting condition, we may consider patient 2 worse than patient 1. But when we make these patients pedal, we realize that patient 2 has a sort of homeometric adaptation to exercise. Volumes, especially end systolic volume, does not change. We have a mild increase in end diastolic volume, contributing to increased stroke volume, while patient 1 has a steep increase in PAP, has a dynamic and very rapid right ventricular dilation, both in terms of end systolic and end diastolic volume, and loses completely the isovolumic contraction, suggesting the development dynamically of severe TR. So by looking at what happens during exercise, we can really realize the pathophysiology of patients. And even if we do not dispose of pressure volume loops, we have shown that we can gather the same information from three-dimensional echocardiography that we can quite easily perform together with right heart cath, and that may provide the same information in terms of homeometric versus heterometric adaptation. So with this, I would like to conclude, and I'm open to your question and remarks.
Thank you so much, Sergio, for this presentation. It was terrific, really. Big, deep into physiology of RV, pulmonary artery, and LV. I remind everybody that they can write question in the chat. I'm happy to read. And in the meanwhile, if Dr. Yard has no question or still thinking, I will start with one. Okay.
I do have a question. Can you hear me?
Yes, please, Dr. Yard.
Terrific lecture. Very practically, do you think you can make a diagnosis of HFpEF without doing an exercise right heart cath?
Yes, we can do, but we may miss a lot of early HFpEF. Now, we may debate on the utility of diagnosing early HFpEF. This is another point, but I have several cases in which we have very important hemodynamic aberrances during exercise despite normal, near normal echo or natriuretic peptides.
And in the same vein, I almost disagree. I almost think you have to do a right heart cath. But in the same vein, if a patient has severe tricuspid regurgitation, and then the right atrial pressure does not increase significantly during exercise, do you think their benefit from an intervention is the same as those who increase the pressure?
Well, we have no data
So I'm asking you.
certify this, but I think, well, I do not think that TriTAR cat provides all the answers. So it is an exam to be put in context with all the rest. But if I have a patient with low cardiac output, lower than expected increase in cardiac output, even if right atrial pressure does not increase that much, and I can attribute the lack of increasing cardiac output to tricuspid regurgitation, I may anticipate that he or she can benefit. So it depends on the clinical context and on the analysis of all the elements. I do not think there are magic numbers, so everything is to be put in context.
Yeah, I think fair enough. You know, you showed some of the shunts that are being used and try to treat HFpEF, and you know, I'm somewhat involved with the left atrial to coronary sinus shunt, and not to speak about the shunt per se, but the an important entry criterion for that study is actually an exercise right heart cath. You can only get in if you have an exercise right heart cath. So let me rephrase my initial question. Do you think before placing a shunt to treat HFpEF, one needs to perform an exercise right heart cath?
I think so, because but mainly to avoid situations in which mainly because tricuspid regurgitation may occur dynamically. If we perform an interatrial shunting in a patient who has dynamic TR, benefits may be attenuated as compared with a patient who do not have dynamic TR. And by looking mainly at right atrial pressure, so I think that in the field of interatrial shunting, proper hemodynamic phenotyping may be useful.
Maybe useful.
Even though maybe useful, maybe.
Thank you.
Okay, Sergio, I have a question for you. So, you know, HFpEF is this disease that we've been told for years, treat the underlying causes, give some diuretics, and hope for the best. Now we have SGLT2 inhibitor that seems to do something more. In your experience, have you observed any improvement, for example, of the slope, wedge cardiac output, or other parameters with the use of some more specific treatment right now?
Generally, we do not perform right heart cath after initiating SGLT2 inhibitors, so we do not have these data. Barry Borlag and colleagues showed us that wedge pressure absolute values can be reduced by SGLT2. I have to admit that if I have a patient who is really congested, also hemodynamically, he or she generally benefit of it. While patients that put in the upright position who have very low wedge pressure in the upright position generally tends to develop malaise or lightheadedness when treated with these drugs. So this is my only point. But in the very congested patient, in the patient in whom wedge pressure is high at rest and increases steeply during exercise, well, they seem to work quite well.
Okay, thank you so much, Sergio. We have a question for the audience. Dr. Sims, one of the advanced heart failure cardiologists, very expert in right heart catheterization too, is asking if looking at exercise right heart variables to diagnose HFpEF, absolute wedge obtain over and CVP over cardiac output slope, does this help you with determining the severity of the disease? For example, this patient I refer because based on their other testing, we are not so sure if they have a HFpEF. So are these patients with more mild disease or can they have very severe disease like patient with terrible resting hemodynamics?
Yes, I think um, I did not understand properly the question. Sorry.
So the question is, how these tests, first of all, help determining the severity of this patient?
Well, we have several variables. The extent of raising in wedge pressure tell us something, but mainly I'm personally feared by the increase in right atrial pressure. I think that patients who present with a steeper increase in right atrial pressure and accordingly a shallower increase in wedge pressure because of ventricular interdependence may have the worst phenotype. And we have some data suggesting that when right atrial pressure increases steeply, this is a worse phenotype. The other aspect that we can get, but I'm not sure it's really for clinical practice, is the behavior of pulmonary vascular resistance that should physiologically decrease during exercise. We have shown that if this is not the case, if patients present with higher than expected pulmonary vascular resistance during exercise, they generally have also higher right atrial pressure, and they may have a poorer outcome as compared with patients in whom exercise PVR is lower.
Okay, thank you so much, Sergio, for your answer. So if no one else has other question, I think we can give a great thank you for Dr. Caravita for spending his time with us and adjourn to next week.
Yes, thank you. Thank you so much, Sergio. It's really terrific.
Thank you.
Thank you. Goodbye. Have a nice day.
Bye.